Hi friends, in this class we will continue our discussion regarding VKC, the treatment part. Okay, so the grading part and the treatment part. So the grading of VKC, there is one Nikhil S Gokhale classification, which is based on the features, clinical features in bulbar, conjunctiva, tarsal, or the palpebral part, and the corneal involvement as well as the limbal inflammation. So this classification was found to be very simplistic and just based on its anatomy, and it has no implications while using for the treatment. So we wanted a classification through which we can plan the treatment of this, because there has been a very much use excessive use of steroids in these cases. So that's why Bonini et al classification is now considered as a gold standard for classifying VKC cases, and it is divided into four grades based on the findings in the conjunctiva, cornea, as well as the environment. So grade 0 is quiescent stage, in which there are no symptoms and no treatment is required in such cases. And grade 1 is mild, grade 2 is moderate, grade 3 is severe, and grade 4 is blinding. So in grade 1, the symptoms are present. As we said, the symptoms include burning, itching, watering, and all. There is no corneal involvement in mild cases, and the treatment is with anti-allergic medications. So we can use antihistaminic and mast cell stabilizers. So in moderate ones, there are symptoms along with corneal SPKs, which are moderate in nature, and these anti-allergic drugs are needed on a daily basis when there is an exacerbation of the symptoms. In severe stage, there are symptoms photophobia due to those SPKs and the corneal involvement, as well as the limbal involvement is more than 6 clock hours. There is limbal inflammation, right? In moderate cases, the limbal involvement can be less than 6 clock hours. Coming to the treatment of severe cases, along with the anti-allergic medications, we have to give topical pulse low-dose steroids. In stage 4, that is blinding stage, we have all the above symptoms. Along with, there is corneal ulceration. So here we have to give the above treatment, and along with that we have to do a surgical management of the corneal ulcer, that is removal of the plaques. So this is Bonini et al classification. Now coming to the treatment part. So treatment is topical as well as systemic. So in early stages, just topical is enough, whereas in severe stages, systemic medications can also be added. So coming to the topical treatment, we have anti-allergic medications, as we have discussed. The anti-allergic medications, these include antihistaminics as well as mast cell stabilizers. So we have olopatadine, ezilastin, ketotifen. Okay, so these are mast cell stabilizers. It is sodium chromoglycate. So these olopatidine elastin, they have dual mechanism, that is antihistaminic as well as mast cell stabilizing features. So sodium chromoglycate 2% is used and olopatidine 1% is used. And other first generation antihistaminics like phenylephrine, nafazoline and all can also be used. We have steroids, then topical steroids. So there are low potency steroids and high potency steroids. So for the early stages, low potency steroids like fluoromethalone, loteprednol, and metrisone can be used. So fluoromethalone is the least potent of all, whereas this betamethasone, dexamethasone, and prednisolone are high potency steroids. So these are reserved only for very severe cases, and these are commonly used post-operatively, right? So the complications and all are low with the low potency steroid related complications. Okay, so that is regarding steroids. Then we also have topical immunomodulator drugs, that is cyclosporine as well as tacrolimus. So cyclosporine can be used 0.5 to 1% as a freshly prepared drops, and tacrolimus is available as 0.03% ointment form. So these are reserved for refractory cases only, because there are other side effects related to these immunomodulators such as corneal drying and secondary ulcerations. Then we can also use lubricants as artificial tears and mucolytics. These carboxymethyl cellulose, hydroxypropyl methyl cellulose, sodium hyaluronate drops, and mucolytics like acetylcysteine. So these are used when there are more ropey kind of discharge. Now coming to the systemic medications, we can use the same antihistaminics like montelukast, levocetirizine and all. We can use systemic steroids in very severe cases. So what we say there? So yes, we have ALHM protocol. So this ALHM protocol, ALHM, is step ladder wise treatment which we have to use. So A here means anti-allergic or anti-allergic avoidance. So that is preventing the disease, and L includes lubricant, H is histamine, antihistaminics, and is the mast cell stabilizers. The step ladder approach for treatment according to grading includes, for mild cases just ALHM is enough. Okay, so that's according to Bonini Et classification. For mild cases we do this ALHM protocol. Then for moderate cases it is ALHM along with steroids, that is low potency steroids like loteprednol, pulse dose. For severe cases, ALHM along with a high potency steroid, and also cyclosporine can be used, that is immunomodulators, and high potency steroids are reserved for severe cases only. For blinding ones, we have to use potent steroids and along with some surgical approaches such as supratarsal injection of steroids in case of cobblestone papillae and tacrolimus or cyclosporine, that is immunomodulators. Eye drops can be used and surgery for ulcerations should be done. So this was the treatment protocol, that is step ladder approach, so that we make a rational use of steroids in these cases. Okay, so coming to a black box warning, so there has been a warning by the US FDA for tacrolimus and pimecrolimus. So they have said these have the tendency, they can cause cancer. So that's why they have come with this black box warning for this. So cyclosporine is relatively safer. So we have to reserve this tacrolimus in refractory cases, and it should not be used before the age of 2 years. Whereas this cyclosporine can be used and it has to be freshly prepared in the form of eye drops. Yes. So cyclosporine is safer. Cyclosporine in 2% doses can be given for cobblestone papillae. In case of cobblestone papillae, a little bit higher dose like 2% can be used. So it can be prepared with artificial tears as well as oil based. So oil based can be kept for 1 month, whereas artificial tears we have to prepare it fresh and give it to the patient. So there is multiple visit required. So this was regarding the treatment. Thank you.